So no disclosures, and this talk is typically given by Dr. Bhatt, but I will do my best here. It's an overview of FDA-approved treatments for opioid use disorder. And the objectives are to become familiar with the 3 FDA-approved medications for treatment of opioid use disorders, and be able to help your patient choose between the different treatment options, and then to feel comfortable working with a patient who's on medication for their opioid use disorder. So the key message here is that detox alone does not work. And this quote by Walter Ling that is quite good. Detoxification from heroin is good for many things, but staying off heroin is not one of them. So to keep helping people in order to not relapse. So detox and the drug-free approach, this was the traditional model. And the detox without subsequent medication support may be helpful for very, very highly motivated individuals who have a stable environment, but otherwise without medications, what we see is that up to 90% of patients who go through detox relapse in the first 1 to 2 months off of medication. And of those who relapse, some may die of an overdose. So the key to keeping people alive, the message from this is to keep them on the medication. This study in the Lancet from 2003 was a pretty well-referenced study that basically looks at people who are who stay on buprenorphine versus those who go through a detox. And you can see that in green. And with the detox group, and then going on to placebo after 1 week, 4 of the people died in this study, whereas those who remained on buprenorphine stayed in treatment. And this is looking out basically a year, stayed in treatment, and there were 0 deaths. So at this point, this kind of trial would not be repeated, but it's quite clear the importance of staying on medication. So we'll talk a little bit about the role of these medications. So what are the outcomes with methadone? We see a decrease in heroin use by 50%, a 4-fold decrease in transmission of HIV. We see increased employment of 24%, and we see a significantly decreased criminal activity, 60% less. There's less incarceration, less other high-risk behaviors. We see more child support payments, so lots of positive outcomes. And importantly, that folks who stay on methadone are 3 times as likely to remain in treatment than if they go through detox. We also see improved treatment adherence for hepatitis C treatment in folks who are on methadone maintenance, and decreased mortality. It is cost effective to stay on methadone. And people who use drugs who are not in methadone treatment are more likely to become 6 times more likely to become HIV positive than those who remain in treatment. So many, many reasons for methadone to be continued. What are more benefits of maintenance treatment? We see a lot of decrease of high-risk behaviors, so decrease of injection drug use, decreased sharing of needles and other supplies, decreased associated drug use, so cocaine use, decreased unprotected sex, decrease in the multiple sex partners, and decrease in commercial sex work. So this slide is looking at crime among 491 patients before and during methadone maintenance treatment at 6 different programs. And I believe that this text was out of New York. I don't see it there, but the Ball and Ross text. And you can see big difference before treatment being pink and after and during treatment being yellow. So a few more thoughts on this. Medication can be one part of a more comprehensive treatment program. So it is important to also integrate counseling or therapy. Case management for a lot of our patients is quite necessary and helpful. And then other forms of health care, such as primary care and psychiatric care. And oftentimes being on methadone can kind of help people become more engaged with these other treatments. So thinking of it as a hook that can lead to more engagement. In this way, we can also help treat underlying illnesses such as PTSD, hepatitis C. We can help with stabilizing other important things in their life like employment and housing. Being on methadone can help them patients create positive social networks that were sometimes broken during their drug use. And also the therapy can help them learn coping skills, relapse prevention strategies, and emotional regulation strategies. So what are the FDA-approved medications? So we'll talk about, there's three. Methadone is a Schedule II medication. It's very highly regulated. It's been around for decades, and it has to be prescribed for opioid use disorder only in OTPs or narcotic program treatment settings. It's a full agonist at the mu receptor, which is the receptor in the brain where opiates work mainly. It has a pretty weak affinity for it, meaning that it binds to it pretty weakly, and that's important in terms of other opiates might displace it, and we'll talk about that a little bit more with buprenorphine. Who is appropriate to be on methadone? We need to document that they've had at least a year of dependence on the opioid or opioid use disorder. And we do need parental consent if they're ages 16 to 17. And also in that age group, they need to show that they've had at least 3 prior attempts with detoxification before considering methadone. Methadone does have some treatment barriers. It's considered out of the medical mainstream, so methadone clinics are, this goes with the location as well, tend to be kind of on the periphery of society, so they can't be near any sort of central locations, so they're sometimes hard to get to. So there's some stigma that's associated with specialized clinics. A lot of times it's hard for patients to feel accepted by going to a clinic that's particular for methadone for their opioid use. Like I said, the location can be a barrier. It can be several miles from where someone works or lives. And then it's required to dose daily at the beginning of treatment. And so once you've been in treatment for I believe three months, then you can start getting more take-home doses so that you're not going to have to go necessarily every day, but it can take up to 2 years to get, or at least 2 years to get a full month's take-home. So that can be burdensome for some people, especially if they're trying to get to work. And then the federal regulations, again, are very strict, and that can be helpful from a safety standpoint, but it can also present some barriers in terms of, again, getting the flexibility to dose at home. So now let's talk for a bit about buprenorphine, which is the partial agonist. Remember, methadone is a full agonist at the mu receptor, and buprenorphine is a partial agonist, meaning that it partially stimulates it, but it has a ceiling effect where it's not likely to cause overdose in people who are already tolerant to opioids. So it was first made possible to prescribe a Schedule III opioid. Buprenorphine is a Schedule III opioid by the Data Act in 2000, and that's at that point when physicians received a X waiver to prescribe. In 2002, the FDA approved the sublingual form, and with that Data Act, physicians are required to have an 8-hour training, and that X number that follows their license, and having up to 30 patients of active prescriptions in the first year. And then after that, providers can apply to treat up to 100 patients. In 2017, I guess, the CAR Act was passed, which was really crucial legislation so that nurse practitioners and PAs also prescribe, and that's really opened access significantly for patients. And this requires a 24-hour training that includes that 8 hours plus additional modules. As I said, it's a partial agonist at that mu receptor. It comes in film and tablet form that has to be absorbed under the tongue. It is not meant to be swallowed. There's also a long-acting injection, monthly injection that's available. And it, again, it has less risk of respiratory suppression because of that ceiling effect. So for folks that may have experienced overdose before, let's say on methadone, or if we're concerned because perhaps even though there is a risk as well with benzodiazepine, but if they have other risks for respiratory suppression, this may be safer to be on buprenorphine. The dosing is usually between 4 and it's approved for 4 to 32 milligrams. We don't recommend going above 24 milligrams because that tends to saturate the receptors and have not really more effect. And most people, a target dose of 16 milligrams is quite effective. It can lead to withdrawal if it's started when another opioid is already sitting on those receptors. So unlike methadone, buprenorphine binds really strongly and clings to those receptors, and it will push off something like methadone that has less affinity for those receptors, and it could make someone withdraw. So for starting buprenorphine, they do need to be in withdrawal, mild to moderate withdrawal before starting it. What are some benefits of office-based treatment? It's private, and confidential can be provided in the provider's office, and so they might not have that same stigma. They can check in, say, for their blood pressure and also be seen for this. Allows for continuity of care with their primary care provider. It doesn't require daily visits, and so the cost perhaps of transportation and distance is less. It allows more time, therefore, for folks to have with their families and for employment. So we see also improved access just because of the ability to be seen in their clinics. And we see that it's about as effective as methadone at reducing opioid use. It has, at this point, been shown, however, to have slightly less retention in treatment. And that could be due to the structure, perhaps, of methadone programs. Cochrane review, this is a meta-analysis of 8 studies through 2006 of 1,068 people, and methadone was more likely than buprenorphine to keep people in treatment, but there were no significant differences in their opioid use based upon toxicology results. And then the third FDA-approved medication is Naltrexone, and this is an antagonist, meaning it blocks that same receptor. So we have our full agonist, our partial agonist, and our antagonist at the mu receptor. It comes in a daily pill and an injection. The daily pill has not been shown to be effective for opioid use disorder. If we're going to prescribe that, it's usually for alcohol use, which is its other FDA indication. The injection, however, given every 4 weeks, it can be an effective strategy. Some recent studies have shown that for many patients, it can be as effective as buprenorphine. However, it's harder to start because you have to wait longer to take that first dose. So with buprenorphine, for instance, you have to wait just to be in mild to moderate withdrawal, so sometimes 12 to 24 hours after their last opioid use. With Naltrexone, it's recommended to wait at least 7 days in most cases, so that you've really cleared out the opioids from those receptors, and that can be very hard for people to do. So I think at least one of these studies, right, Dr. Bhatt, it was an inpatient where they were able to start it, and they found effective outcomes, but again, they started inpatient. It's also very expensive in the injectable form. I believe it's about 40 times as expensive as the pill. And it does not have any addictive potential. And once people are on it, if they were to stop it, they would not withdraw from that. Okay, so how do we choose which one in the last 10 minutes here? Okay, I see. So selection of candidates for naltrexone. So for patients who are interested in, or for some reason, perhaps for their profession, they can't be on agonist maintenance therapy, such as methadone or buprenorphine, it might be appropriate. They would be recommended to have a lot of motivation for abstinence and really being active in therapy or perhaps groups. And again, as I said, the professions such as healthcare professionals or pilots, the agonist just may not be an option, not an option. And then might be an option for patients who were successful on agonist therapy but want to try being off. Some people just feel very strongly that they want to be off of any agonist medication, and so if they're very motivated, they may want to try the naltrexone. And then perhaps for people who failed prior treatment with the agonist and continue to use heroin, so still very high-risk behavior despite the agonist treatment, they may be candidates for antagonist treatment. Do you want to say any more, Dr. Bhatt, about this slide? I'm not sure if I covered. Okay. And again, those who are at risk for relapse, so for perhaps somebody who's been off of opiates for some time, however, they're going to be going somewhere where they may be triggered more easily, such as old neighborhoods, or they have increased stress, or worsening psychiatric problems. It may be a time to consider initiating antagonist therapy. And who are the patients who are better candidates for agonist therapy? So patients with histories of overdoses, especially after they've come off of medication, so they should really be continued on an agonist or partial agonist. And for those who have serious mental illness or particularly disorganized homeless populations, these folks are also better candidates for agonist therapy. And then for patients who have been off of opioids for a time but have never felt normal off of them, they're perhaps craving, at risk of relapse, they would also be people to consider starting this medication, one of these medications. So patients in whom psychiatric illness emerged or worsened after previous detoxifications would also be candidates. Patients with chronic pain who require chronic opioid treatment may do better on an agonist type therapy. Pregnancy is a time when certainly it's recommended to be on buprenorphine, the mono product Succotash, or methadone. And then to be sure, of course, to consider how much patient choice matters, so having a full evaluation and discussion about treatment options. This is just a chart comparing buprenorphine and methadone. So a lot of this I think we already went over, so I'm not going to read through it. One thing to keep in mind that I think I didn't talk about yet, we already talked about, for instance, that buprenorphine has some less barriers in order to receive it, more access to it. It has less regulation, and so sometimes that needs to be factored in terms of having some procedures in place, perhaps to check on diversion. Sometimes what we'll do is callbacks to do occasional film or pill counts, things like that when you're prescribing buprenorphine. It's not required, but there are things in place that can help try to ensure against diversion. Same with methadone, we have those structures in place. The side effects tend to be pretty low with buprenorphine. In methadone, because of it being a full agonist, we need to check, be a little more careful to check about sedation. And with methadone, in terms of ease of use, one thing that it can affect is the QTC interval. So an interval on the EKG that if it's too long, we worry about potentially fatal arrhythmias. And so it's important to check that, especially at higher doses of methadone. And then there tend to be less interactions with other medications for buprenorphine than methadone. So one example are medications to treat HIV. And this question comes up all the time. I'd say, how long do I stay in treatment? And really the answer is as long as it's benefiting the patient. So other things to keep in mind, at the right doses of these medications, the patient should feel normal. So what is normal? Meaning there shouldn't really be any withdrawal symptoms. There also shouldn't be any feelings of intoxication, and they shouldn't be sedated. Cravings might not be completely eliminated by the adequate dose, and so that's really where therapy becomes essential to kind of help some of those relapse prevention skills, and that can improve with time. For, as I said, the methadone, we check the EKG, and then it's important to talk with patients about discussing their medication prescriptions. Sometimes people also, the flip side, don't feel comfortable talking with other providers if they're on methadone or buprenorphine because they're afraid about how they may be perceived. So I always try to talk with people about trying to be open with that just for safety reasons, but it can be difficult at times for folks to talk about these medicines. Naltrexone can't be combined with any opioids, including methadone and buprenorphine, because as we discussed, it can cause someone to withdraw. It's difficult to switch from methadone to buprenorphine. It's certainly possible, but it does take a longer time to get into withdrawal. And so the other way around, however, switching from buprenorphine to methadone, even though we have to step up gradually in the methadone dose to get to an adequate dose, they don't have to be in withdrawal at that kind of transition. That can be easier transition for people to make. And then we need to encourage patients to avoid other substances, particularly ones that can cause respiratory suppression, such as benzodiazepines, soma, and alcohol. And again, try to keep people in treatment as long as possible. Again, as we went over before, that discharge from care is really likely to increase overdose and death. And sometimes patients may need a more intense level of care, but they should stay on these medications. And then it's good to consider the role of integrated clinics. So clinics where patients can receive their agonist treatment, but also other medical care, psychiatric care. Having daily contact with patients at a methadone clinic can help them also receive better care for other health concerns. So we see rates of treatment for primary care at 92% versus 35%. Dr. Bhatt, is that in methadone clinics versus not being on methadone?
Yeah.
For tuberculosis with directly observed treatment completion, if they're being seen for methadone daily, and this goes back to that slide about kind of having methadone as a hook to help with treatment of other things, HIV treatment. And then 81% of patients who inject drugs used on-site primary care services, with care being used more by HIV-positive patients. Interesting. Okay, so I guess that was actually the last slide to go. What